Swapnil. I am associate. Okay, we are start recording. Okay, so I am Dr. Swapnil. I am working as associate consultant at Apollo Hospital in critical care medicine department. That means ICU. This is our 33rd educational series, which is today's topic is airway management guidelines, and we have got our speaker, Dr. Amla Kudlakar. She is a senior professor at KM Hospital. We have got our moderators, Dr. Gunadhar Padi. He is a senior consultant and working HOD at our department at Apollo Hospital, Navi Mumbai. And we have got Akhilesh Tandekar, who is also senior consultant and working as intensivist at Apollo Hospital, Navi Mumbai. So this is our team. Other than that, we have got two fellows, Dr. Sumant and Dr. Hariya. So we all welcome you all candidates to take benefit most of this topic. Gunadhar sir, over to you.
Thank you, Swapnil. And so today will be very interesting session, I suppose, because this is one of the basic skill what an intensivist must know. And to continue the medical education and training, this is our 33rd of this Apollo Mumbai Critical Care Learning Program, where we encourage all the practicing intensivists, anesthesiologists, registrars to be expert in the critical care management. And since my teacher, Dr. Amla Kudalkar, is here, she is one of the pioneer, I can say the master in this field. So who can teach better than the airway skill for the intensivist? So I will be happy to welcome Madam, and Madam is working as a professor in the and HOD in the Department of Anesthesia, and she was our teacher, and she has a vast experience in the field of anesthesiology, airway management, and in Sion Hospital and across all the municipal corporation hospitals in Mumbai, and that's why we have invited here. And Madam will teach us the different guidelines and how to basically one should be expert in this field. And with this, almost 50 students have joined. Without further delay, I welcome Madam to this platform, and I welcome Madam to start her own lecture. So, Madam, please start the session. Thank you.
Yes, thank you, Gunadhar. I welcome all of you for this lecture. It is really a commendable initiative by Apollo Hospital and you too, Gunadhar and Akhilesh. And thank you for making me a part of it. I really appreciate it. Airway is very close to my heart, and hence I would be very happy to go on with this lecture. I'll be speaking on airway management in ICU. I'm unable to carry the, yeah. And this is a place where I work currently. This also happens to be my alma mater. Let's start with a case. An elderly male patient was rushed inside an ICU, obviously in respiratory distress, accompanied by an intern and relatives, but without any papers. I mean, this is a common situation that we come across day in, day out, if you remember your SOTRR days. Ideally, the ICU team should have been informed about the patient shifting and history in brief. This helps the ICU team to be prepared for the likely intervention. You know, if depending upon the history from the, say, ward sister or the surgical resident, you know that this patient is likely to require intubation and you keep everything ready. Also, a responsible person should have accompanied the patient along with the papers. Anyway, this patient was a known case of COPD. He was operated for total gastrectomy under general anesthesia with and thoracic epidural. 2 days later, the patient developed severe respiratory distress. ABG, which was sent from the ward, showed severe hypoxia and he was retaining carbon dioxide. PCO2 was 83 millimeters of mercury. Now it was JR2 in the recovery. So he decided to intubate. Patient was very agitated and therefore he decided to give fentanyl. 50 micrograms IV he ordered the sister to give. and he attempted intubation with Macintosh blade. The patient was struggling, had to be restrained. Intubation was not possible. So, because the patient was moving too much and fighting, he decided to give propofol. With propofol, the BP dropped to 66 millimeters of mercury. Okay, so second problem started. So, inability to intubate and hemodynamic instability. To combat this hypotension, injection ephedrine was given and intubation tried again. With ephedrine and with struggling patient and intubation attempt, the BP shot up. Yet the cords were not visible. Then the JR2 decided to use McCoy blade. With McCoy blade, the Cormac-Lehman grade was 3B. Even though it was 3B, he tried using a bougie. Now all this maneuvering caused dental trauma, bleeding, and VLS was asked for at this juncture. It took 90 seconds to retrieve the VLS from the safety of the locker with the staff nurse. Meanwhile, senior call was sent and intubation was attempted with VLS. Now at this juncture, the resident could not see much because of secretions, because of blood, because of the exhaled moisture as the patient was breathing continuously. At this time, the senior help arrived. He tried intubating again with McCoy blade. Patient was intubated, apparently, but the air entry was doubtful. Ventilation continued, the saturation dropped, bradyarrhythmias. And then you can imagine what must have happened. All throughout, the saturation kept falling. And as the Murphy's law says, if anything can go wrong, it will. It proved here. Now, day in, day out, we do intubation inside OR. So what was so different here in ICU? Is there any really different thing in ICU or intubation or airway management apart from OR? Well, of course it does. It was the 4th national audit project on major complications of airway management in the UK, which was published in 2011. It was by mainly Tim Cook, which showed that nearly 20% of the major airway events were from ICU. And of this, almost 60% led to permanent neurological damage or death. And the gap analysis, all these events were analyzed, and the gap analysis showed mainly it were the human factors which were at work. So which are those? Poor identification of at-risk patients. The person did not know that there can be risk involved. Delayed recognition of events. Even though the tube is in esophagus, they failed to recognize that. They failed to recognize the patient was hemodynamically unstable. Then lack of proper plan. Even if there was a plan, they did not possess the skilled staff and equipment to carry out that plan. And then failure to intubate the critically ill patients. Not only that, failure to rescue techniques like face mask ventilation or supraglottic airway devices. Unrecognized esophageal intubations, failure to interpret capnography. For that matter, capnography was not used in this patient. Other things which can happen is displacement of a tracheal tube and tracheostomies, especially during transfer. Now, this patient, if you need to take to CT scan or MRI, or even if you wish to change the patient's position for dressing of, say, bed sore or so, the airway, the definitive airway can get misplaced and it may not be recognized in timely. There can be delay in the recognition of displacement. So all these are the human factors which are at work in ICU. And that's why there led to lot of studies over this. And this is one of the very good article in British Journal of Anesthesia, where airway management inside and outside OR. This is an editorial. So what is so different? Inside the OR, it is elective intubation, which is done in a stable patient with good physiological reserve. and by a skilled anesthesiologist. Now, if you see, this was a patient with BMI of 40 kg per meter square. As against this, the ICU intubations are always under duress and with time constraint. The incidence of complication also is very high, 22 to 54%. So what makes it more challenging? It is the deranged physiology in critical illness, which makes anatomically normal patient physiologically difficult. Anatomically, patient is perfectly normal, but patient comes to you with a blood pressure of 60/40 or so, or with hemoglobin of 4. Then naturally it becomes physiologically difficult airway. That means the patient is not able to tolerate the desaturation or a lack of oxygen even for a moment. Most of these patients are not fasted, or even if they are fasted, their emptying time is increased substantially. Often these airways are not evaluated prior. Limitation on use of pharmacological agents. Now, if you are starting BP is 70 millimeters of mercury, it is very difficult to give any kind of intravenous anesthetic agent. Dealing with the extreme agitation, shock, and bronchospasm as our patient, it is not possible to intubate a struggling or fighting patient. Limited space and limited access to airway, poor lighting. Now, if you need to squeeze yourself between the head of the bed and the wall, it will be very difficult. You are not at all in your comfort zone. Suboptimal positioning of the patient's bed. Awakening the patient is not possible. That is not an option. You have to go ahead and intubate. And lack of experience and training, because most of the ICUs are managed by residents in the after hours, or even not, non-anesthesiologists may be there. Many a times BAMS residents also may be there. So all this exerts lot of cognitive overload on the patient, impairs decision making and performance. Tracheal intubation without planning can lead to utter chaos and confusion. We just saw one case. It can lead to wrong treatment, wrong sequence, poor consequences, and therefore you should have a systematic approach. You have to make use of algorithms and cognitive aids. And in general, your ICU has to be prepared. There has to be a preparedness from everybody. Now, how we want to deal with such situation? In a normal patient, if your patient is posted for any routine surgery, you would like to assess the patient preoperatively by taking history, by examining the patient, especially stressing on his airway examination and stabilizing the patient prior to actually going ahead with induction. Here it has to be done simultaneously. I mean, you cannot wait for your complete history to be over, then you will examine. Everything has to be simultaneous. So check history with the surgical resident, relative, whoever is accompanying the patient. See what is the presence of illness, present illness, what are the comorbidities, what medication the patient is on. Any surgeries were done in the past, any complications. History of difficult intubation in past. If there is, then most likely even this time it will be difficult. Check for the fasting status. Even if the patient is fasting, that is what the history you elicit, believe him to be full stomach. Any contraindications to the use of succinylcholine that you must ask for. Start oxygen. Now simultaneously this has to go. So as you ask the relatives and resident, you start applying the monitors, start oxygen, give head-eye position, check for vitals, pulse, blood pressure, saturation, auscultate the chest. Look for the patency of pre-existing IV. If it is not, then you will have to secure an IV line. And if you have the facility, quick USG for lung conditions and IVC collapsibility. So that will give you an idea about the hemodynamic status and the lung condition. Second thing is assess the need for tracheal intubation. Just because the patient comes on a trolley from the ward as an emergency, it may not mean that you need to intubate him fast. First, assess. Check whether the tracheal intubation is needed or no. Let's come to next case. 45-year-old morbidly obese patient was posted for open CBD exploration. She was given standard general anesthesia. Post-operatively, she was well reversed and extubated on table and shifted to high dependency unit by resident anesthesiologist. It was again first-year resident. He went to recovery, started oxygen by mass on 5 liters per minute. After 20 minutes, we received an urgent call in OR as the patient had desaturated. We rushed there. The patient was drowsy. No, the patient was given oxygen, but she lay down in a head. She was not given in head-eye position. She was in supine position. Breathing was obstructed, seesaw type pattern, and saturation was 82 and down. Patient was quickly given head-eye position. Airway was opened using head tilt chin lift maneuver. A small shoulder pad was given so as to cause the extension of airway. An appropriate size nasopharyngeal airway was inserted after lubrication. Patient was ventilated by bag and mask with airway, a high flow of oxygen. So we opened the airway, then we started ventilating the patient with bag mask and oxygen. Soon the patient recovered and started responding. Patient was maintained on CPAP of 10 centimeters of water by mask and gradually weaned off over the next 24 hours. The point to tell you is not every patient would require intubation. So you have to judge what is the real need for intubation. What the patient requires is an open airway and oxygen, sometimes under pressure, so CPAP. So opening the airway, again, give head-eye position, opening the airway by an appropriately sized orotracheal or oropharyngeal or nasopharyngeal airway. So judge the size appropriately. If it is too big, it will stimulate the larynx, epiglottis. Not only that, it can push the epiglottis below, so as to block the laryngeal inlet. If it is too small, then it will not serve the purpose. You can give high concentration mask or you can give CPAP. So different levels of gadgets you can use depending upon the patient's condition. Indications for tracheal intubation would be if there are obvious signs of respiratory failure, like anxiety, sweating, tachypnea, air hunger, use of accessory muscles of respiration, seesaw breathing pattern, altered mentation, signs of exhaustion, etc. If the saturation is low and still going down, ABG may show hypoxia, hypercarbia. Sometimes because the patient is tachypnic, he is washing out CO2s, PCO2 may be unusually low. If the lung ultrasound is suggestive of any pathology or X-ray chest shows any pathology, if the patient is in shock, severe anemia, if the patient has hemoglobin of 4 and breathing, then that it is not an indication, just give oxygen. Sometimes in the future, the patient may require, till the blood is given and patient is stabilized, the patient may require intubation and ventilation so as to give rest to his respiratory system. Obviously, post-arrest, protection of respiratory tract from aspiration or for tracheobronchial toileting or for bypassing the airway obstruction. So these are the indications for tracheal intubation. Normally, if you are, for any routine case, you do thorough airway examination and there's a battery of cases, small tests that you are doing. Usually, multiple tests will give you a better idea about the level of difficulty of the airway. All these things may not be possible in a patient who is admitted in ICU. Patient is lying down in supine position, may not be conscious, may not be able to comply. But what you must do is rule out the red flag signs like obvious trauma, facial, cervical, oropharyngeal tumors which are existing or post-operatively because they have reconstructive flaps or they have received radiotherapy of the neck, making it absolutely rigid. Other systemic diseases having airway issues like rheumatoid arthritis, ankylosing spondylitis, airway burns, etc. So red flag signs you must immediately rule out. Does it mean that you should not carry out airway assessment? Absolutely not. You must carry out airway assessment for, around 5 to 10 seconds also suffice. A quick assessment. It may be difficult in obtunded or uncooperative patient. Many a times the patient is receiving oxygen by mask, and to check the MPC, you don't want to remove the mask, fearing that he will become hypoxic. So you can start nasal oxygen and then can check MPC. MPC is valid in supine patient with voluntary mouth opening. So in supine position, you ask the patient to open the mouth and you can check MPC, and that will be valid enough. A quick laryngeal handshake to locate the cricothyroid membrane. Nowadays we tell everybody. And if you have USG, keep identifying the CTM size, cricothyroid membrane for its size, depth, overlying blood vessels or thyroid tissue should you require to do a cricothyroid puncture. Now this is a Makocha score, which is by which you can identify the patient with likely difficult airway. These are the various factors which are related to patients, like Malampati score. Makocha is an acronym, so M for Malampati score of 3 and 4. It receives highest points. Obstructive sleep apnea syndrome, 2 points, and the remaining reduced mobility of cervical spine, limited mouth opening, each carry 1 point. Factors related to pathology. So this is the beauty of this score, that it considers all factors, coma or severe hypoxemia, and factors related to operator. So if the operator is non-anesthesiologist, then 1 point is to be considered. So overall, there are 12 points. This is the only validated airway assessment tool in critical care. The maximum score that you could have is 12, whereas score of 0 will indicate easy intubation. Anything more than 3 would indicate difficult intubation, and as it approaches 12, then the degree of difficulty goes on increasing. Now, this is a receiving area which you will find in every recovery room or ICU. It's a dedicated area, a bed reserved for receiving the patient. Patient will usually come on trolley. Once it will have one set of monitors, one ventilator, absolutely standby monitor, and then it will have difficult airway card, difficult set of monitors, ventilator, full crash cart, airway trolley, ambu bags you can see here, and oxygen source should be present. Also, there should be a tray filled with syringes of emergency drugs available, emergency as well as induction drugs. So aspirated and ready. So this is a receiving area. This is a close view of this. Now, this is a crash cart. Crash cart, you can, each gadget or related to airway should have a specific place. And that gadget should always be in that place once it is used. It should never lie. At the last moment, you will not get even 10 extra seconds to achieve airway. Everything should be there. So once used, it should be washed, cleaned, and it goes back into this tray. The contents of each tray or drawer should be mentioned outside. This is the interior. So if you say face mask, all the face masks should go back to this area. Supraglottic airway, endotracheal tube, etc. So all these trays you can prepare as per your own protocol or availability of the gadgets, but this is must. Not only that, you should have this pasted, and you can ask one of your juniors or even sister to fill this, assess. This is the, excuse me. This is the Alfred's checklist. It shows there are various points which are written, assess. So after doing that Makoja or any other, is the difficult airway predicted? Is there any risk of physiological compromise? I mean, if there is cardiovascular instability, hypoxemia, acidemia, increased ICP, so rule out all these factors. Are the ICU consultants aware? Do they know? Usually they are in the side room only. So they should be actually told or informed about this patient. And are anesthetists or ENT surgeons around? So all this should be checked. Usually it is tick marked, so it is very easy to fill. If you do this for 15 patients consecutively, you don't have to look at the chart also. But you should run the mental checklist before you approach any patient. So is monitoring ready? Is equipment checked and ready? Are drugs and lines ready? Have team roles been assigned? Usually the senior most will be team leader and he will assess the roles to the juniors. Is the patient optimized? So check whether the position is optimized, oxygenation is started, ventilation is ready, hemodynamics are checked. All these points should be checked. And then you announce what is your plan A. This is what the checklist is all about. And that will, because failure to plan for the failure is a major cause of airway catastrophe. So all plans, not only the plan A, but if you are not successful with plan A, what should be your next plan? Or even not that, then what should be your plan C? All should be in your head right from the beginning. And the equipment and the skilled person required to carry out that plan should be available immediately. Now, what is the role of intubation bundle? Now, bundles are a small, straightforward set of evidence-based practices which, when performed collectively, improve the patient outcome. If you go through the ICU books, there will be many bundles, like bundles for the central line cannulation, bundles for any procedure that you carry out. So these are a set of evidence-based practices, small stepwise practices which are written, and you have to go according to that. And this is what it mentioned that, see, the incidence of severe hypoxemia or severe collapse or cardiac arrest is considerably low in the intervention group than in control group. So this group is the intubation bundle was followed, and this was done without any prior intubation bundle. So as in when whatever happens, in that case. So in general, the complication rate is much reduced if you follow the bundle. So this is just one example. So bundle will have pre-intubation, during intubation, and post-intubation steps. So pre-intubation usually presence of two operators. One of them should be an expert in airways. Fluid loading, because when you give any anesthetic agent, usually it causes drop in blood pressure. So it is better to preload these patients with isotonic saline or ringer lactate 500 ml or starch. Now, if the patient is not in cardiogenic pulmonary edema. Use of starch in critical care situation may be doubtful, but you can always give crystallized. Preparation for long-term sedation. Pre-oxygenation for 3 minutes with NIPPV. Now, these are all the steps. We are coming to it in subsequent slides one by one. So I'll just rush through that. Now, this was a INTUBE study. Intubation practices and adverse peri-intubation events in critically ill patients. It was done in all 5 continents in 29 countries in 917 different centers, 197 centers. It was carried out. You see, our own Sheila Nainan Matra, ISCCM chief, she was there involved in this study. To assess the incidence and types of major adverse peri-intubation events in critically ill patients, to examine which factors were associated with these events, to determine the association of adverse peri-intubation events with outcomes among critically ill patients. And a peri-intubation event was defined as at least one of the events occurring within 30 minutes from the start of intubation procedures, such as systolic blood pressure less than 65 millimeters of mercury at least once, less than 90 millimeters of mercury for more than 30 minutes, new or increased need of vasopressors, fluid bolus if there is requirement is more than 15 ml per kg to maintain the hemodynamics, severe hypoxia which is less than with saturation less than 80%, or cardiac arrest. So these were the primary outcome. And this was the secondary outcome that were looked for, like incidence of arrhythmias, difficult intubation or CVCI situation, emergency front of neck access, aspiration of gastric content, esophageal intubation, injury, etc. So all these were studied factors. And what they found was it was the cardiovascular instability which was maximum. This event was maximum. Almost 42.6% patients had cardiovascular instability during access to airway. 9.3% had severe hypoxemia, arrest in 3.1% patients, out of which 47% it culminated in death. Esophageal intubation was in 5.6%, difficult intubation and aspiration 3.9%. So overall ICU mortality was 32.8%. This is what their studies indicated. Now, when they analyzed these events further, actually the standard protocol was in place and used in 51% patients. In 62% patients, rapid sequence induction was used. So and so forth. Propofol as an induction agent was used in 41% patients. Probably that led to hemodynamic instability. Most of the patients, 75% patients, muscle relaxant was used for intubation. Use of VLS as a primary device for intubation was used only in 17%. Now, if you were to do this study again, probably this proportion would increase. Very surprisingly, waveform capnography to detect correct placement of endotracheal tube was done only in 34.5%, and that is most unfortunate. So further guidelines were done by IDA, our own Indian guidelines in 16, and British Journal of Anesthesia guidelines in 2018 for management of tracheal intubation in critically ill patient. So now how do we get ready for intubation? Presence of two operators. I already mentioned one expert in airway management. So say one senior consultant and one resident. Check for patency of intravenous line. If not, then take one dedicated and definitive IV should be there. Then you run an IV bolus of 500 ml crystalloid. You don't have to wait till it is over. If the blood pressure is on lower side, then you can immediately give this, provided there is no cardiogenic edema. Keep vasopressors ready in case BP crashes after induction. So if diastolic BP goes down, immediately you can give either phenylephrine boluses or noradrenaline. Most of the ICUs which will have usually the noradrenaline infusion ready with mounted on the infusion pump. Good working suction ready, oxygen source equipment, ventilator ready and set. Induction agent and muscle relaxant aspirated and ready. So this is how you get ready for intubation. Now, what position should be given for intubation? Ideally, patient should always be nursed or in ICU or intubated in 25 to 30-degree head-eye position. As it improves upper airway patency, it improves the FRC. In this position, the patient may have little hypotension. In that case, you can raise the legs also, something like Fowler's position. Now, this is the difference between the sniffing position. In sniffing position, it is a flat bed. Bed has to be firm. It is a flat bed, and then over that, you raise the patient's head. So there is flexion at the cervical spine and then extension at the atlanto-occipital joint. As against in ramp position or in head elevated laryngoscopy position, it is the entire torso which is raised above the level. And that is what makes the face flat. The patient face should be flat, and there should be a line joining the tragus and the suprasternal notch. It should be in one line. In patient with suspected cervical spine instability, the head should be placed in neutral position and manual inline stabilization can be given. However, the entire bed can be made head high so as to improve FRC. So this is the basic position that you give for intubation. So whenever permits, you give this. If there is hypotension, you raise the legs. So patient is sort of in V position. How do you pre-oxygenate a patient? Is it really required? Because there is so much urgency of intubation. Well, in hypoxic patient in ICU, the usual pre-oxygenation is ineffective. Even increasing the duration of pre-oxygenation does not increase the PaO2 proportionately. In a normal patient, suppose the PaO2, any patient undergoing surgery, if PaO2 to start with is say 80 to 86 millimeters of mercury, if you pre-oxygenate the patient well, the PaO2 can go to as high as 250 to 300 millimeters of mercury, but not in patients who are, in critically ill and respiratory failure because of lung pathology or any other disease. It fails to rise to same proportion. If it is 60 to start with, it may rise to say 80 millimeters of mercury. So there is no substantial increase. So then how do we face this situation? Use a tight fitting face mask. Start high flow of oxygen, say up to 15 liters per minute. If you have a facility to record, just aim at ETO2, end tidal oxygen, of more than 85 to 90% and give CPAP through mask. You can see here, through the mask. In severe cases, you can use HFNC. But mind you, when you are giving HFNC, high flow nasal cannula, along with tight fitting face mask, there can be sudden rise in pressure because with HFNC, the oxygen is going at a very high flow of up to 60 to 70 liters per minute. So there can be severe barotrauma. So avoid. HFNC is given when you want to do endotracheal do fiber optic intubation also. At that time you can give. Otherwise, start NIV. NIV with pressure support of 5 to 15 centimeters of water at FiO2 of 1. The supported breath should generate an exhaled tidal volume of 6 to 8 liters per kg of ideal body weight and start PEEP of 5 centimeters of water. How does NIV help? It unloads the respiratory muscles. It causes recruitment of the alveoli and increases the lung volume. So it prevents that collapse of the alveoli that occurs with usually supine position and after induction of anesthesia. Not only that, it prevents absorption atelectasis, which is very common after giving 100% oxygen to the patient. This is more of theoretical. If you remember our first patient who was agitated and fighting with the anesthesiologist, the patient may not allow you to tight fit the face mask to him. And therefore, there is a concept of delayed sequence intubation. That is small doses of sedatives such as injection ketamine. Give small doses, 0.5 to 1 milligram per kg, which are given prior to pre-oxygenation in an agitated patient so that the patient calms down and accepts your oxygen face mask easily. So this is called as delayed sequence intubation as against the rapid sequence intubation. NIV, it has been found that those patients who received NIV, the incidence of severe hypoxia was 10% as compared to the control group with an incidence of 25%. So whenever patient is in respiratory failure, always give NIV. Up till now, we saw what is pre-oxygenation. Now there is another entity that is per-oxygenation, and that is no-decide technique. So nasal oxygenation during effort securing a tube through nasal cannulation. Always, if you have an auxiliary port of your anesthesia machine, you can start an additional oxygen by giving by using nasal prongs. Attach it to the auxiliary port, and before you apply oxygen face mask, you start this nasal prongs, and then you start with giving the high at 15 liters. 15 liters through face mask as well as 15 liters through your nasal prongs. Now, during intubation, you are going to remove the face mask. At this point, the patient is not breathing on his own and patient is apneic. And you are not giving oxygen. So the patient can desaturate very fast. That's why you keep giving this 15 liters per minute of oxygen through nasal prongs so that the FRC is filled with oxygenation. All this. If you have HFNC like Thrive, transnasal humidified rapid insufflation ventilatory exchange, where as I already mentioned, 60 liters per minute of humidified and heated oxygen is given, then it will be still better, because not only it gives positive pressure because of that high flow, so it has that CPAP like effect. It causes flushing of the dead space. It causes mass flow of oxygen and causes CO2 clearance. So in apneic oxygenation, usually the problem is with CO2 washout. If you, whenever you are giving it for, say, carrying out scopies. So here, not only oxygenation improves, but even CO2 is washed out. And this is what you see here. This is face mask. This is the HFNC which is attached here. And this is when this person is intubating, the high flow of oxygen is still going to the patient. So it improves the PaO2 of the FRC. So how to reduce the risk of aspiration? Most of the patients in ICU will have enteral feeding going on. So ask the sister, when was the last feeding given? If you are contemplating intubation, withhold the last feeding. Even whenever the feeding is given, just a few minutes or hours back, consider it to be full stomach. So suck out the remaining gastric contents by nasogastric tube. Leave the nasogastric tube in place and keep it open. That is what the latest guidelines mention. There is no need to bring it out into esophagus. Laryngeal handshake to know the position of cricoid. Application of cricoid by a trained assistant. If it is not given properly, it does not serve any purpose. Not only that, it can hinder your intubation. When the patient is awake, 10 Newton, that is 1 kg of pressure is applied, and then it increased to 30 Newtons after loss of consciousness. Force should be reduced or removed if there is difficulty in mask ventilation, or while during passage of endotracheal intubation, or while passing or whenever there is active vomiting. Because if you give cricoid pressure, continue with cricoid pressure, patient is vomiting actively, that time there can be sudden rupture of the esophagus. So you don't want that. In head-eye position, regurgitation doesn't occur. Most of the time, the aspiration occurs because of regurgitated matter is getting inhaled. If you anesthetize the patient well and give muscle relaxant, there is unlikely that there will be vomiting. So no aspiration. Now this is how cricoid pressure is given. Laryngeal handshake, you locate the cricoid. Always give bimanual cricoid pressure, bimanual. How does it help? By pressing the cricoid again, by pressing the esophagus or the cricopharynx against the body of the sixth cervical vertebra. If you give with one hand, when you apply pressure, it causes flexion of the neck, and then insertion of laryngoscope will be difficult. So always with this, you steady the neck and then give pressure. If you feel that the operator is unable to insert the laryngoscope further, or if the patient is not getting ventilated during its application, you release the cricoid pressure. Initially, around 15 years back or so, ICU patients were always intubated, struggling. People were scared to anesthetize them. A small dose of midazolam or fentanyl used to be given, but patients were not anesthetized or paralyzed as you could do in the OR. But nowadays the concept has changed, and it depends what kind of drug you are using depends upon the hemodynamic stability and state of consciousness. Usually, a small dose of midazolam or fentanyl would also help to reduce the dose of anesthetic agent that you wish to give. The drugs of choice for induction, many times we have given injection propofol, but invariably afterwards the patient has developed hypotension or so. Now injection ketamine in a small dose up to 1 milligram per kg body weight or etomidate 0.2 to 0.3 milligram per kg is considered as a drug of choice because they are cardiostable. So whenever not contraindicated, you go ahead with this. Etomidate causes, even single dose may cause adrenocortical suppression, so you have to be careful. And then where should muscle relaxant be given prior to that? Of course, they should be given. Why? Because they improve the intubating condition. Imagine a struggling patient and against that a calm patient. He will allow face mask ventilation as the chest wall compliance improves. Will allow SGA insertion, relieves the laryngospasm. So all these are positive findings. So whenever possible, you must give muscle relaxant. Now, which muscle relaxant to be given? Succinylcholine has been the mainstay in dose of 1 to 1.5 milligram per kg. So initially, remember, we have already ruled out contraindication to it. A quick glance at the serum potassium will help you decide. Now, some people do not like to give succinylcholine. The advantage of succinylcholine is it causes great intubating conditions within 60 seconds, and still better is the offset is quick. Now, this can be both advantage as well as disadvantage. Advantage in a sense, you can have access very early. But if it is difficult intubation, then and if you are not able to achieve intubation, so the patient keeps coming out and then struggles. Then you don't know whether to give next dose of succinylcholine or go for non-depolarizing muscle relaxant. Another problem is it produces hyperkalemia. The muscle fasciculations that it causes increases the oxygen requirement, and then that's why it is some people do not wish to give it. It also increases the ICP or IOP. Therefore, some, especially on western side, they prefer injection rocuronium because it causes similar intubating conditions within 60 seconds. However, one thing we have to remember that it is a long-acting agent. So if the airway is difficult, then and you are unable to gain access to airway, then you can be in problem. So in UK and all, they will recommend because they have Sugamadex at hand. What is the role of rapid sequence induction intubation? Patients in ICU are at higher risk of aspiration. They may not be fasted. They might have received food just prior. The gastric emptying time may be deranged because of underlying illness as well as the drugs that are being given to them. And the presence of RT may render the LOS incompetent. However, nowadays they recommend leaving the RT in place. Not ventilating the patient during apneic period may cause severe desaturation. So what is RSI? That you give a fixed dose of drug and then without ventilating, give cricoid pressure and intubate after a certain time. So it may cause severe desaturation, and rapid administration of IV induction agent may cause hemodynamic instability. Therefore, nowadays it is recommended that modify rapid sequence induction intubation is done, that is graded doses of induction agent, cricoid pressure, and gentle IPVV. This is a prevent study where back mask ventilation during tracheal intubation of critically ill adults. So it was multi-center RCT involving 401 patients in 7 different ICUs. 2 groups were done, one ventilated with back mask and others were not ventilated. So the primary outcome was lowest oxygen saturation reached in the interval between the induction and 2 minutes after tracheal intubation. And secondary outcome was to study the incidence of severe hypoxemia defined as saturation less than 80%. And then it was seen that patients who received back mask ventilation had significantly higher saturation and a lower incidence of severe hypoxemia. Not only that, operator reported aspiration occurred in 2.5% in back mask ventilation and 4% in non-ventilated group. So continue gentle ventilation if hypoxia is imminent. Then choose your primary device. There are multiple devices are available. Choose a one with which you are comfortable. I would like to go ahead and say that it is better that you make yourself comfortable with most of these devices which are available in your hospital. So it is not that just because you are not used to a particular device that you should not be using. Just make yourself comfortable. Use it again and again. It is the training which matters. Do it on your mannequins or all, but get used to all the devices of Airway that are available in your hospitals. It would be a shame that VLS is available, but you don't know how to use it. So keep practicing. What is important is timely or traumatic intubation with minimum number of attempts. Now, should VLS, what is the role of VLS in critically ill patient? We know that it improves the Cormack-Lyon grade by 1 to 2. Also, change of head neck position is not required. And it's possible to watch intubation by seniors, so who can guide you actually, So it is all good. However, certain bad points in the sense you have to remember that a pogo, or if you see the entire laryngeal apparatus 100%, doesn't always guarantee successful intubation. So it can be little treacherous. Insertion of endotracheal tube into glottis is more difficult. At this juncture, I would say always go for combination techniques with intubating bougie or stellate. Even if you see the larynx staring at you, always make use of a bougie, non-traumatic bougie. Do not use a bougie with stellate, but use a simple intubating bougie and thread the tube over that. Insertion of blade in the mouth may be difficult because of the short neck or flexion. In that case, the monitor can be fixed later on. Just insert the blade first, and then in case of say King's vision, just insert the blade first, and then after that you attach the monitor. The exhaled moisture, secretion, blood makes the visualization difficult. So as in our first case, when VLS was resorted to as a after first 3 to 4 attempts, that should not be the case. Because for VLS, the insertion or the visualization of larynx depends upon its visual mechanism. So you should use the VLS or any fiber optic bronchoscope, etc., in a virgin airway, which is not tampered by other equipment. So these are the various VLS which are available. What commonly I think we are used to is CMAC blade, Macintosh, or hyperacute. Remember, with hyperacute, always make use of a bougie. There some can be channeled or some can be non-channeled. So as I mentioned earlier, use a gadget that you are comfortable with and often use in combination with bougie. Sometimes now recently in this in Tata Hospital DAC conference, we learned the use of hybrid technique. I mean, you use the video laryngoscope so as to see the vocal cords and or the epiglottis, which is covering the vocal cords, and then below that you insert a lighted band. Either use fiber optic or use a light band. And on the light band you have mounted your endotracheal tube. So all the time you are under vision. So making use of hybrid technique, use or 1 or 2 extra gadgets. And this is again a meta-analysis involving RCTs and observational studies. This particular study involves 9 trials with 2000 plus participants. And it concluded that VLS reduced the risk of difficult intubation. It decreased the incidence of Cormack-Lyon grade 3 and 4. It reduces the incidence of esophageal intubation and increased the first attempt success rate. However, patient all developed severe hypoxia, severe cardiovascular collapse, and airway injury. So that was not reduced. Another study where patients with MPC grade 3-4, Makocha score predicting difficult intubation, and where the non-expert operator was there in the intubation. These patients were studied. In them, the incidence of difficult intubation was 47% in a normal, in a Macintosh type of laryngoscope. Whereas in VLS, the incidence of difficult intubation was 0%. So even though it was predicted difficult, if you are using VLS, the incidence of difficult intubation is always negligible. So you consider VLS as it was considered as VLS as a first line or after the first attempt failure using direct laryngoscopy. So what I mean to say is use it early. So this is again the 2018 British Journal of Anesthesia guidelines. A video laryngoscope should be considered as an option for all intubations in critically ill patient, and those involved in critical care intubation should be appropriately trained in the use of video laryngoscope. They may be called upon to use. If difficult laryngoscopy is predicted in a critically ill patient, like with Makocha of more than 3, video laryngoscopy should be actively considered from the outset. If during direct laryngoscopy there is a poor view, subsequent attempts at laryngoscopy should be performed with video laryngoscope. I think I have made it very clear. Now, after intubation, you have to confirm that your tube is in proper position. So age-old stethoscope, of course, it is there. You can check with the exhaled moisture which appears on the endotracheal tube. But when the patient is agitated, when it's coughing out, when there is bleeding, whenever the patient is in having bronchospasm, both all these things may confuse you, as it happened with our patient. So what matters is the waveform capnography. That should be your final endpoint. A square wave pattern on in waveform capnography is all that you should aim for, not even saturation. Normally placed, even now, if you have USG, you can make use of that. So this is a normally placed endotracheal tube, and this is a collapsed esophagus. By chance, if your tube is in esophagus, then you will see there will be two trachea. One is normal trachea, and one is the esophagus in which you have which is intubated by you. This can happen real time, so you learn this also. So capnography, and if required, USG. In the NAP4 project, it was mentioned that capnography was the single change with the greatest potential to prevent deaths. There are multiple others about the proper positioning. Now you know that the tube is in place, but whether it is properly placed or if it is one-sided, two-sided, then along with capnography, you can check again with your USG. USG probe kept in the suprasternal notch, and then you assess and then make it vertical. And this is the saline filled cuff, which increases the penetration of the USG rates. Absent lung slide, presence of lung pulse. So if there is unilateral tube is endobronchial, then on other side, there will be absence of lung slide and presence of lung pulse. These are the IDA guidelines for tracheal intubation in intensive care unit. I mean, you go through these are freely available. So IDA 2016 as well as BJA 2018 guidelines, you must go through thoroughly. And not only that, you can make a, enlarged Xerox and put it in your ICU. So there, whatever we have described so far, they have mentioned same. 2 persons, 1 experience, then pre-oxygenation, start with NIV, pressure support, PEEP, nasal cannula continuously, so no DSAT technique, HFNO if required. So everything they have given systematically. They have also given, if this happens, well and good. If it doesn't happen, then what to do? So if it doesn't happen, if you are not unable to intubate, continue nasal oxygen, direct or video laryngoscopy, maximum 2 attempts. Now the difference between the British guidelines and our guidelines are, we are more cautious. So we do not give the operator that third chance. So it is 2 plus 1 chance. So 2 are by the junior or the person who is not expert. The third attempt is reserved for an expert in the airway. Similarly, in the British guidelines, there are 3 plus 1 chance. So 3 by the junior person and 1 by the expert. So all this you have to go through that. I won't go through each and everything because we have already discussed that. So step 2 will be laryngoscopy and tracheal intubation. If there is failed intubation, try and insert SAD, supraglottic airway device, to maintain oxygenation. Now, at this juncture, you can, if you have fiber optic, you can pass in a fiber optic through HGD and intubate through that. So, but never blindly. If there is failed ventilation through SAD, then straight away cricothyroidectomy. IDA mentions it is cricothyroidectomy, thyroidotomy. So it is not front of neck access, because cricothyroidotomy, it conveys the meaning that it has to be done in the cricothyroid membrane. Okay, so cricothyroidotomy is an emergency procedure. Tracheostomy can be elective later on. So this is just I have made based on these guidelines. So maximum 2 attempts only if saturation is more than 95%. Mask ventilation in between the 2 attempts. Now the second attempt should not be same as first. You have to do something different. So just try changing the position, do release of cricoid pressure, change of device, change of bougie, person, etc. And declare the failed intubation. After that, insert second generation SAD. Why second generation? Because of their high ceiling pressure and because of the gastric drainage tube that they have. Again, maximum 2 attempts, that too if saturation is more than 95%. In between the 2 attempts, keep ventilating. Again, second attempt, do something different. And throughout the procedure, maintain oxygenation, maintain anesthesia, and maintain relaxation. No point in trying this in a struggling patient. And then if you cannot do, then just declare it is complete ventilatory failure. Now, ventilation should come first. If you aim for CICO, cannot intubate, cannot oxygen net, then you have probably reached the end of the entire procedure. So do complete ventilator failure. So the moment your ventilation fails, you declare that it is severe emergency. Don't wait for that oxygenation to go down. So rescue face mask ventilation, ensure adequate muscle relaxation. If unable to ventilate, declare complete ventilatory failure, and then do surgical or needle cricothyroidotomy, and then pressure regulated jet ventilation. If you achieve this cricothyroidotomy, if you are able to put in a cannula, immediately try to convert it into tracheostomy at the earliest. This remains same. This is the British guidelines. They have given 1 extra attempt at laryngoscopy. Now, something about this vortex approach. Initially we said that you are giving 2 attempts with HGD or 3 attempts with HGD. If that fails, then you are going to face mask ventilation. Actually, if you see in between, it should be, together. I mean, in between you are doing HGD ventilation, you are trying to insert HGD. If it fails, then you remove the HGD, try and do face mask ventilation. So you are doing one alternatively. It is not that after 3 attempts of HGD, you should resort to face mask. You can do that alternately. So that is what it mentioned. It is a vortex. So it avoids repeated attempts of the same technique when difficulties arise. So permit a maximum of 3 attempts of each technique by HGA face mask ventilation. So this and this together, 4th attempt has to be by expert. And mandatory switch to phone up. So whenever you feel that you are trying intubation, you are trying HGD, and you are trying face mask ventilation, if it fails and you are going down this vortex at the nadir of the vortex, you just declare that now at this juncture, we have to go ahead with phona. After you are able to intubate, check for the leak. Either you can see on the volume graph scalar, or you can actually see it here. The difference between the set and the exhale tidal volume. Always inflate the cuff. Some people, because the patients are going to remain in ICU for a long time, some people would like to inflate the cuff with lignocaine, alkalinized lignocaine. It continuously diffuses across the cuff wall and anesthetizes the tracheal mucosa. It decreases the endotracheal tube-induced emergence phenomenon. And the total requirement for sedation, fentanyl and propofol, decreases by as much as 30%. And the frequency and severity of cough decreases significantly. Keep securely in place. Now, many a times because of the suction is drooling, right? Always use, keep the patient dry. Keep the tube on a place where the tube remains in a non-dependent position. Use the commercially available tube holders. Post intubation, always check for X-ray chest. Ideally, the tip of the tube should lie at least 5 centimeters above the carina. You can see it here. This is the tip. This is the carina. So this is the margin. If it is too much inside, this is what happens. One lung is totally cut off. So always take a X-ray chest. Even if your cuff is inflated, some amount of aspiration may occur if it is not properly placed. So position the patient properly in head-eye position. Check for any leak in the cuff or whether there is endotracheal tube is dislodged and without feed prior to extubation. So what you require is feeding surveillance. Many a times you have used a cuffed endotracheal tube, but usually it is the secretions accumulate above the cuff. And that's why you can use endotracheal tube with subglottic secretion drainage port. This is cuff and there is a port here. There is a small hole in the shaft of the endotracheal tube just above the cuff. A channel runs through the inside the wall so that it can be sucked. Otherwise, these accumulated secretions can, very sheepishly go by the side of the cuff and can cause aspiration. So this is supposed to be better to prevent a development of VAP. Avoid any drag on the tube. See all the circuit, it is pulling the entire tube outside. And if this is because of secretions, it becomes soil, then it can entirely, the endotracheal tube can be, there can be accidental extubation. This is the disconnection. So keep eye and ear on your ventilator alarms. So any circuit disconnection, low airway pressure alarm, or if you are using ETCO2 module, then that will also give alarm. So do not silence your alarms. Pay heed to your alarms. Obstruction of endotracheal tube can occur because of the kinking, because of the secretion, clots blocking, or if you are using HME for a long time. Usually you need to change your HMEs every 24 hours. Because of the accumulation of moisture inside your HME, there can be excessive pressure. So whenever you change HME, always put a stick-on plaster and write when you have changed the HME. So next day you have to remove it. So regular humidification, inline manual suction. If the patient is going to be intubated, remain intubated for a long time, you always put this inline and suction catheters. Continuous ETCO2 monitoring. Now this I have added just to say that throat pack, whenever the patient of especially airway surgeries is shifted in the ICU, always put on his forehead, throat pack in situ. If many a times surgeons like to put this end of the throat pack also inside, and then person who is there, unless proper over is given, the resident just extubates this patient, and this throat pack in the throat can cause obstruction to the patients. These are the accidents which are very common in the ICUs, which are airway related. And you can go through this article. This is by Farhad Kapadia from Hinduja Hospital. These accidents are common with tracheostomy tubes, and they tend to occur in the first 2 days when the track is not well formed. They are more frequent in children, and they can lead to unplanned extubation. This is the common mishap that can occur. This is a misplaced tracheostomy tube causing subcutaneous emphysema because you continue to ventilate, but the tube is not in right place. What should you do when there is unplanned or accidental extubation? The incidence is quite varied, 0.3 to 30%. Usually it occurs because you have somehow delayed the elective extubation. Patient is ready for extubation, but you haven't extubated the patient. So the patient does the job for you. It also happens because you have not given proper sedation in ICU because of the lack of communication with the patient. Improper tube fixation, all these factors can cause accidental extubation. If the patient is fit, then consider this as a extubation trial. Continue to observe him. If the patient is well and good, then keep him extubated. However, if within minutes the patient develops hypoxia or arrest or immediately these are the patients who would require immediate and reintubation with sedation and paralysis. Extubating the trachea. Extubation is an elective process and therefore it has to be done. It has to be done in such a way that no harm is done to the patient. So patient has to be absolutely fit for extubation. Usually, it can be a challenging task in case of already difficult intubation. Second thing is the patient's intubation may be normal, but now since the patient is on 3 to 4 days of ventilatory support and is intubated, patient could have developed airway edema because of prolonged intubation, capillary leak, or fluid resuscitation. And therefore, though intubation was easy, extubation can prove to be problematic. Always do cuff leak test. You deflate the cuff and see whether there is any leak in the tidal volume. One can do staged extubation also. Either use Bailey's maneuver, so remove the tube, but behind that put in a LMA, or still better or safer would be you extubate the patient over airway exchange catheter. So in the end, just to summarize, you go through your protocols, checklists, bundles properly. You should know them by heart. Your ICU has to be prepared 24/7. Anytime you need to gain access, quick assessment of the airway is essential. Positioning pre and post oxygenation must. Achieve mastery over devices which are available in ICU. Limit the number of attempts. So follow the guidelines. Confirmation of the tube placement by capnography, definitely. And what you require is support of hemodynamics also. So you choose your drugs wisely, give vasopressors, give preload the patient. All these things you must do. Thank you for your attention.
Thank you, madam. Thank you for such an elaborative, extensive, and I think talk, and most of the aspects of critical care, anesthesia, and airway management has been covered here. So I think this is one of the very extensive talk and detailed, and this is very useful to the all the upcoming intensivist. I can say the budding intensivist. Almost we have 100 the students and intensivists who have joined this program. And on the behalf of them, I have only very few questions, madam. Like one is intubation protocol in COVID. So what is your experience? Though we have our own set of SOPs, but if anything can be new and something can be adaptable, it will be helpful for us.
Yeah. See, at that time I was in Sion Hospital. My voice has become hoarse. So that time initially, we were really worried for ourselves as well as the patients, and we were defensive. Since we did not know the exact nature of the disease, we were overcautious. So what we used initially, we used that intubation box. Tried, even in routine patients also we tried. But intubating through that box had a high learning curve, and it did not serve the purpose I thought, because afterwards the entire thing and extubation everything went haywire. Probably we did not probably stick to the guidelines properly. But later on, as we were more familiar with the disease and how to do things, what matters is N95 mask on you and face shield and oxygenation. I mean, the patient also should have a mask on till the time of pre-oxygenation. Means intubation, pre-oxygenation also was through the mask. So that is what we followed. And then we did not ventilate the patient, pre-oxygenated the patient well, gave that extra oxygen, no DSAT technique. So continued the oxygen during the intubation, but we did not ventilate the patient. We always use video laryngoscope as our first choice. So it is, it is not a question of you try once or twice with other laryngoscope, then the saturation falls and then you had to ventilate, nothing like that. A senior intubates uses a video laryngoscope. Everybody watches it that the tube is going inside the trachea, and then immediately attach it to the circuit. Inflate the cuff and attach it to the circuit. So there is no that air going into the theater. So that is what we followed. Usually these patients were also hemodynamic unstable. So our as I you also have worked there. So
Yes.
one noradrenaline was always prepared. And whenever possible, we used to attach it earlier. What I prefer personally is I usually carry one phenylephrine syringe, 10 microgram per ml. And immediately, by the time that drip goes and you don't know somebody starts the pump, this really does wonders. So you give initial 1 or 2 doses of phenylephrine if there is drop in the diastolic blood pressure. And then by that time, the noradrenaline will start taking its action.
Yes, yes, ma'am. So thank you for this wonderful discussion. So basically, what Madam summarized, basically the each and every intricate aspect of airway management, and everything is being covered. Actually, so what is more important for a critically ill patient is not only the airway but associated problems with associated condition which is existing for that particular patient. Like the patient might be in shock, the patient might be having airway bleeding, the patient might be in thrombocytopenia, he might be in coagulopathy, and also he is having other issues like raised ICP. So that is what actually differentiates it from the typical elective patient who are being done in the OT. So if the person who is intubating not only has to take care of the airway, but he has to also take care of the associated conditions, how to manage the hemodynamics. That is the most important part. How to start early vasopressor, or if the how to do a proper preloading. So not to forget these 7 P's, like the preload, the preparation, which is more important, what Madam highlighted, the pre-oxygenation, the something called as the preloading and passage of endotracheal tube, and the intubation bundle, and after that the how to put the patient on the ventilator, like checking every aspect of the circuit, HME filters, and proper setting the ventilators, and give a proper sedation so that the hemodynamics will not be changed, because it has been found that 50% of the complications during intubation, for any critical patient, the 50% of the complications occur during the airway handling. And we have many cases we have witnessed where during intubation the patient has crashed, and most of the times if the patient is very sick, sometimes we have to give a CPR. So that is the reason optimizing hemodynamics before doing an airway procedure as quickly as possible is that important, and also to follow the difficult airway guidelines like Plan A, Plan B, and Plan C with all the advanced gadgets. Of course, ICU is a place where we have all the gadgets like your video laryngoscope, bronchoscope. We are ready with the percutaneous tracheostomy. So do not forget to call for the help. That's what I have learned from my junior days, and that's what Madam has taught us actually. That is the most important part. So never try to do heroism and heroic things. So, and rather say sorry before something has went wrong. That is the main reason. Always try to involve seniors and experts who are actually belongs to the field of airway, like a senior intensivist or senior anesthesiologist, or try to call for help from the OT, try to call from her help from the ENT surgeons or any person who is expert in that field. So that only improves the outcome for a critically ill patient. So, Swapnil, you have any queries from the chat box?
Sir, as far as queries in chat box, no, sir. But I myself have one question. I need to ask about the cuff inflation technique. Where can we place it? In particular, in emergency protocol, emergency airway protocol. Thing is that whenever we are dealing in the ICU, airway management always a part of the treatment. It is not a whole. It is not a whole and soul treatment. So even if it is life-saving procedure, we cannot lose patient in terms of whenever intubating the patient. So that is the thing, emergency airway and others. Otherwise, I will repeat my question. The cuff cuff inflation technique in difficult airway, or where can we use it in terms of just fitting in guidelines?
Yeah. So just before this, Madam will answer this. But before this, there is one question which is actually pertaining to the this something called as particular to the ICU patients, like any patient who is intubated and
Yeah.
developed ventilator-associated pneumonias. Patient is on double inotropic support, good GCS, taking good spontaneous regular breathing. Is it advisable to extubate the patient? This question is put by Dr. Susmita Bhatt. So this is a totally different area. So this is something called as the winning criteria.
Yeah,
So
ventilation. It would be mainly ventilation related.
yes, ma'am. So that is totally a different topic. But for the sake of understanding, whenever you win a patient, the first thing you have to consider that the cause for which you put the patient on ventilator has to be resolved. Because unless until that, whether the patient is put on ventilator for respiratory condition, for respiratory failure, for increased ICP, for post-op ventilation, that thing has to be resolved. Unless until that has to be resolved, then it is very difficult to win that patient. And second thing, this patient is already on double inotropic support. So there are certain winning criteria. I just tell all the juniors to go through the book, so that the patient for the winning ideally should be on minimum inotropic support, even if the
Yeah.
other parameters are looking good. So
If I
probably,
can just intervene,
yes, ma'am.
means my idea is whenever you want to, your one system is, affected. I mean, cardiovascular system requires two inotropes, two vasopressors to maintain its normal function. The other system has to be supported well. There is no point in extubating this patient if the patient is on dual high inotropic support. Once it is on minimum support, then you can go ahead and start winning. This
Yes.
is what my take is.
Absolutely. This is absolutely right. And just go through the other different winning criteria like A, B, C, D, and E. A is for airway problems should be sorted out. B, the breathing should be okay. The cardiovascular system should be within the normal limit, like minimum inotropic support should be there.
Yeah.
Patient should not have any electrolyte dysfunction, diaphragmatic dysfunction, or any brain dysfunction, or endocrinopathy. So these are the all ABCD approach to winning. So madam, like Swapnil's question, so like the cough pressure management. So just take 2 to 3 minutes of highlighting this aspect will be very much useful.
Yeah. So immediately after intubation, you tend to, you tend to empty the full syringe inside the cuff, and that can cause sudden increase in the pressure. Now here usually we would try and keep the intracuff pressure below your capillary pressure, isn't it? Around 22 millimeters of mercury. Now here you have to remember that a critically ill patient, in general, there is a hemodynamic instability and the systolic blood pressure and the mean arterial pressure will be much less. So you cannot aim at that less than 25 millimeters of mercury. So or on the lower side. So it is basically you can if you have the airway pressure monitoring gadget, then you can go on checking the airway pressure from time to time. You have to see the adequacy of the cuff inflation. One is by the manual, or you can on the trachea, as well as you can auscultate over the trachea. You can see on the volume scaler of your ventilator. And as I said, the exhaled and the inhaled volume, there also you can check. And if it is excessive, then you definitely need to inflate it further.
So any correlation of cuff pressure with ml of air pushed? This question is by Dr. Badri. So any correlation, madam, between the cuff pressure with the how much ml of air you normally push basically? Is it?
I cannot tell you offhand because it also depends upon the what size of tube you are putting, isn't it? If you are using a smaller tube, just so as to develop the good seal, you need to push in more air. I will not be able to tell you offhand how much air injected will result in what pressure. Perhaps you will be a better person to tell that.
Yeah, so normally we use now the second generation of cuff pressure monitoring devices like AG Cuffle. So basically, this is a digitally powered cuff pressure measurement devices, where actually, like unlike the other devices where we see that particular pointer to go up when we inflate the cuff. So in some other lectures, we'll take this aspect, but this sometimes help us to our staff in every shift. They measure and they record it actually.
But what I want to ask is, can you transduce the cuff pressure? Can you transduce?
Madam, we have not yet tried for
Means
transducer.
like CBP line you transduce, na? Suppose you have
Yes,
line,
yes.
and if you attach
We
it
have
to
not tried
the
that. We have not tried. I
Okay.
don't think there's a device for that for transduction of this airway pressure.
Yes, yes.
At
So
least
only
we have
thing,
not came across till that time.
we can only measure we can get the value actually on the digital
Yeah.
monitoring.
Mhm.
So this is called AG Coffil, which is actually developed by Bharat Serum now recently. And this is a quite
Mhm.
easy. We found that this is a very handy and quite easy instrument to be used
Okay.
by most of the
Mhm.
intensivists.
Okay.
Ma'am, it's a very much great information you have given on this pressure thing, but my question was different. My question was cuff inflation technique for intubation in difficult airway. Where can we fit in guideline?
Where we can fit in guideline. I did
Yeah,
not
because it is
understand
not
your.
included in guideline.
No, I
Acha, where you can integrate?
Yeah.
I think, see, as soon as you intubate, you need to inflate the cuff immediately. I mean, that goes without any saying that after intubation, you have to immediately inflate the cuff. It is not included in the guideline because perhaps it is just a natural thing to do. Without that, how you are going to see the efficacy of ventilation? Patient is already, exposed. I mean, his airway is exposed to aspiration because of possibility of aspiration, regurgitation, and aspiration. So there is no way that you can wait for the cuff inflation to occur. So immediately after intubation, you inflate the cuff, attach the circuit, and check for ventilation. That is what I feel.
yes, yes, absolutely, absolutely right.
Okay.
But there is no such guidelines. That depends on this basically your individual experience and
The very factor that you are saying that you are doing rapid sequence induction intubation, albeit modified, it means that immediately after intubation, you need to inflate the cuff.
Ma'am, because there is some shortage of time, can we move on to next question?
Yeah.
There's one question asked from Dr. Badri. What sedation relaxant used in patients with acute myocardial infarction with cardiogenic shock, as many crash during intubation? Actually,
Okay.
this question, yeah, okay.
Then perhaps I would use, it depends upon what is the starting blood pressure hemodynamically, and the patient is most likely will be on the inotropic support. But anyway, what I would like to do is give small dose of fentanyl and if required, etomidate.
We generally do the same thing, ma'am. We just give some fentanyl and some muscle relaxant. Probably we always say that if there is any contraindication for scoline or not. And before that, giving this muscle relaxant, we just try to ventilate patient. And patient is ventilating, then only we can give that muscle relaxant. Otherwise, lot many times, whether patient is in cardiac shock,
Yeah, I
patient
did
may
not
be.
get you. You are giving muscle relaxant and then ventilating, no? Or you
No. Before we ventilate, and if ventilation is confirmed, then only we will do muscle relaxant. Otherwise, we will be kept ready all those trolleys of difficult airway. Other than that, many of times this cardiogenic shock patients don't give us time, and whenever there is compromise in the GCS, when there is compromise in consciousness, then we have to make it in hurry with RSI intubation only. That's ma'am. Another question. How much lignocaine and bicarbonate can be used for inflating cuff?
So we don't use bicarbonate. Madam, do you
Yes.
use simply bicarbonate? It is not.
initially we used, that is the article which had come in Saudi Journal of Anesthesia, which I quoted there. But we also put just plain lignocaine, if you remember. We put lignocaine.
Yes. And another question from Dr. Gori, like all the guidelines mention that plan ABC, if SpO2 is more than 95%. Suppose any patient with SpO2 less than 95%, after second attempt of intubation and face mask ventilation, the ventilation is not possible.
As per this, not all guidelines mention that. It is mainly the IDA guidelines. IDA guidelines are little more cautious, that they mention the next attempt is only after if the saturation is more than 95%. If not, then if it is you are unable to achieve that, then I think you will have to go ahead with front of neck.
Yes. So normally this is the action actually which you have to take a quick decision. Basically, you have to involve all your surgical colleague and all your seniors, and as soon as possible you anticipate that the patient you are not able to ventilate. See, the ventilation is most important, because if you are not able to ventilate, there where actually your red flag signs should come in basically. Because intubation per se is not going to, if you are not able to intubate but you are able to ventilate, that you can bring some time for the patient. But if you are not able to ventilate, there where the challenges are. That is why this is one of the important decision you have to take quickly. And
that is what IDA mentions. No, they do not go for CAICO, cannot intubate, cannot oxygenate. They say total ventilatory failure. So they aim to catch at that level, before oxygenation becomes a problem. They want to stay at that cannot total ventilatory failure. So ventilation is a problem.
Yes. So thank you, madam. Thank you for all your excellent presentation. It is, I think, it's all appreciated by most of the students. They have put it in the chat box. And with the interest of time, we cannot take further questions. And
actually, I have written to you. I have some other meeting to attend now.
Okay, madam. No problem. So let's wind up here. And I request Dr. Swapnil to conclude the session. Swapnil,
Yes,
please.
Thank you very much, ma'am. Thank you very much, sir. It was nice presentation, and I think it was very much detailed thing for not only for anesthesiologists but for intensivists also. Other than that, I'll be very thankful to all students who has attended of it, and I will request you to take benefit of it. Otherwise, I'm going to announce one more thing. It will be 21st and 22nd of Jan of next year, which we are going to conduct a top short course for the all exam going students, including DRNB or ADCCM, PDCCM, CTCCM, or EDIC, or any kind of exam you are giving. We are conducting that course which is based on clinical assessment. So unfortunately, it will not be online course, and it will be some sort of mock test. So we are going to provide some questions on beforehand, and we will discuss all those things, the answers, how to write and how to tackle the vivas in examination, and to have more and more benefit of it. So I request all of you to go through the 360 criticalcare.com website, or the brochures we have already circulated in our respective groups. So thank you very much. Thank you very much, ma'am, once again, and thank you very much, everyone.
Thank you.
Thank you.
Thank you. Thank you, sir.